So do me a favor, cover your left eye with your left hand. And I'm just making sure that she isn't cheating and that her hand's totally covering her eye. If you have an occluder available, that's also an easy way to do it. Okay, so just with your right eye, tell me what the smallest line is that you can see on the chart. Very good. Okay, and now switch. And now same thing with the left eye. Good. Okay, so if a patient is able to see 20/40 or better, we kind of let it go at that. If they're seeing less than 20/40, excuse me, I'll use the pinhole occluder to see if there's a refractive error involved. Next thing I'm going to do is check your pupils, okay? So I have a very bright light, I apologize. So I'm going to have the patient focus at distance so that we're not inducing an accommodative reflex and creating pupillary constriction. So the gray light switch, do your best to just stay focused on the gray light switch. Try not to switch to me and focus on the light, okay? So just kind of try to focus on staring off into the distance. And like with any pupil exam, I'm looking at the eye that I'm shining the light in, but as importantly, I'm looking at the eye that I'm not shining the light in, making sure there's symmetry, no afferent pupillary defects, or problems with constriction or dilation. Normal pupil exam, you're doing great. All right, so now we're gonna check your visual fields. So do me a favor, cover your left eye with your left hand. Same thing, I'm gonna make sure that her hand is completely occluding the eye we're not testing. And then I'm going to line up so that our faces are exactly facing each other, our noses are lined up. And then I'm gonna close the eye that is the mirror image of her occluded eye. Okay, Meg, now look right here at my nose, and I'm gonna hold my hands up, and you're gonna notice I always hold up two hands. A patient's natural tendency is if you put up one hand, they're going to move their eye to look at that hand, and that can give you a false reading because that's sort of a way for them to cheat because they see the quick movement and they focus, and then they see what fingers you're holding. So by holding up two hands, it kind of forces them to stay straight ahead and focused. So you're doing great. Look right at my nose and tell me how many fingers I hold up.
2, 5, 1, 2, 1, 5, 2.
Perfect. Okay, switch eyes for me. Okay, and same thing, look right here at my nose. I usually give them a second to adjust to the light because that eye's been closed for a minute. Okay, keep looking right at my nose, you're doing great. How many fingers?
1, 2, 5, 1, 2, 2.
Perfect. All right, very, very good. All right. Next, we're gonna check for motility. I like to use a muscle light with my finger on it. It's just an easy target for both adults and children to follow. So, Meg, do me a favor, keep your head very still, and just with your eyes, I want you to follow my finger, okay? Okay, so and we're checking all positions of gaze. And it's okay, I'm just gonna gently lift your eyelids up. And so what I'm gonna do here is just to make sure that they can move their eyes all the way down, I'm gonna hold the upper eyelids up just so I can get a really good view. You're doing fantastic. Next thing we're going to do is check the intraocular pressure. So whatever device you have available to you, use it. There's another good video that will be published using the Goldman applanation. If I have one available, I like to use a tono pen, especially because as part of an orbital exam, I like to check the intraocular pressure in different positions of gaze. That's very important with things like thyroid eye disease and fractures because if an orbit's very congested or there's an entrapped muscle, the pressure will oftentimes rise in the eye when they go off of central gaze. So, for example, with thyroid eye disease, I always check with the patient in primary gaze and then with up gaze. And if there's a significant difference between those two, that makes me more worried about a congested orbit. Okay. So obviously put numbing drops in. We're not actually going to check Meg's pressure, but I have her look straight ahead. And then the other reason I like to use the tono pen is because you can sneak it in between the eyelids. So even if they're coming in with a swollen eyelid because they've had a trauma, you can oftentimes still check the pressure on the cornea without having to open the eyelids up, the reason I worry about that is if they have a lot of edema in their eyelids and you open it up to check the pressure, you're going to artificially increase the orbital pressure while you're checking it. So just try that sometimes. If you have a tono pen, you're doing a trauma eval on a swollen lid, check it with the eyes open and then check it with trying to just get into the palpebral aperture, and you might be surprised at what a big jump occurs when you are mechanically elevating the eyelids. Okay. All right. The other things we're going to check with an orbital exam, I want to check to make sure that the optic nerve is functioning well. So this test is called red desaturation. Pick up the brightest, reddest object you can find, often the tip of a phenylephrine or a tropicamide cap. One of the red dilating caps is what works really well for me. Okay, so what color is the cap on that pen?
Red.
Okay, and what color is the cap on that pen?
Red.
Is that the same color red between both eyes?
Yes.
Okay, now I want you to look straight ahead at that light switch again. And I'm going to bring this pen in from the side. Tell me if that pen looks any brighter or darker on one side versus the other. Okay, good. So that's checking for red desaturation. I'm also going to check for brightness desaturation. So again, I'm going to have the patient focus ahead. So look at that light switch again for me. I'm going to shine that bright light in your eyes again. I apologize. And now I want you to tell me is that as bright as that?
Yes.
Okay. If the patient's to say no, it's dim in one eye versus the other, there's a couple ways to kind of try to figure out how much loss there is. It's a subjective test, but I like to say things like, okay, if her right eye is the one where she says it was dim in that eye, say, okay, if that's 100% brightness, what percentage of brightness is that? And they'll give you a number like 75% or 50%, and that's just a way subjectively to check it over time, okay? All right, so moving on to an orbital exam, I want to check your eyes to see if one eye is farther forward than the other, okay? So we're going to use an exophthalmometer so that we can measure for relative proptosis or enophthalmos, okay? This works very well if a patient has normal bony structure. This can be sort of a confusing test if they have fractures or facial deformities, but essentially what you're going to do is the curves of the exophthalmometer, I want these curves to rest right inside the lateral orbital rim, and I try to use a target of the lateral canthal angle where that comes together, where that hooks into the lateral orbital rim. That's going to be the points that I'm shooting for. Okay, this can cause a little bit of a pressure sensation for a patient. It shouldn't be sharp, but especially if they have fractures or they're swollen, it can be a challenging exam. But do your best to try to get bony contact with the exophthalmometer so that you have accurate readings. Okay, so look straight ahead for me again, Meg. I'm going to bring these guys in. I'll be as gentle as I can. Perfect. So you can see I'm right at those lateral canthal angles. I'm parallel to the floor. Okay, and then open up really wide for me. And then what I'm doing is lining up the two red lines that you see in there. You want to move your head until those two lines that are sitting on top of each other. That's your 18 millimeter mark. And then you're looking at where the cornea sits on the scale that you see in the prism, and as long as your red marks are aligned, you're square. Okay, so the red line doesn't mean anything except that that's where they happen to place it at 18 millimeters, and you're worried about where the pupil is then sitting on that millimeter scale. If you have them available, I like to use loupes because I feel I can get half millimeter increment readings from the exophthalmometer when I'm wearing my loupes. Okay, and then really what's important with an exophthalmometer is that the same person is measuring it to get the same results. Okay, so I might get a different base than another doctor, but it's more important for me in my records that I keep my base the same, and then I can kind of track changes that way. Okay, all right, the next thing I want to do is gently press on your eyes. Okay, so in an orbital exam, you also want to check for retropulsion. Now that's really important if you have a trauma patient, you're worried about a retrobulbar hemorrhage. You have a thyroid patient, you're worried about a congested orbit, or you have any sort of an orbital tumor and you want to make sure that there isn't congestion in the orbit. Okay, so gently close your eyes for me. And then just with my thumbs, I'm just going to gently press on the eyes. And you'll be surprised at how sensitive your thumbs will be in picking up differences in pressure. And if there's a retrobulbar hemorrhage, it'll be as firm as a rock. If there's a tumor, it should be harder to press in. The same thing with thyroid eye disease. It's a good base measurement, and it's also a good way to track changes over time. So you didn't have any difficulties with retropulsion, so far right now your orbital exam is perfect. All right, so moving on to sort of a fracture exam or a trauma patient, we're going to check to make sure that the bony rims are intact. Okay, so again with my thumbs, I'm going to start at the superior orbital rims, feeling for crepitus over the nasal bridge. Okay, and then I'm going to go from here to the superior orbital rims, and I'm just going to move my thumbs out. I like to do it at the same time on both sides so that I can appreciate if there is a difference. A lot of times you can feel a supraorbital notch, or somebody will have unique frontozygomatic sutures that are easier to palpate, but if it's the same between both, obviously it's less concerning. I do pay special attention to the frontozygomatic suture region because that's a weak point, and oftentimes with ZMC or tripod type fractures, you'll feel displacement in that area. And I work around to the lateral canthus, and then I come down across the medial rim. And again, just palpating and feeling for any step-offs or irregularities in the contour. Okay, so that's great. I don't feel any problems there. Next thing we're going to do is check your facial sensation. Okay, so we want to look for V1, V2, V3, make sure that those are all intact and symmetric. So I'm just going to lightly touch your skin. I want you to tell me if that feels the same on both sides, okay?
Yeah.
Feels the same, good.
Yes.
Okay, so here I check the V1 distribution, V2, and then V3. Does that feel the same?
Yeah.
Perfect. Okay, so far everything's looking really good. Now I want to check for facial strength to see if there was any facial nerve injuries. So lift your eyebrows as big as you can for me. Scrunch those down, good. And now squeeze your eyes as tight as you possibly can and don't let me open them, okay? Good, she has good healthy strength. So that's important for traumas, for strokes, and also very important when you're doing an eyelid surgery evaluation. A lot of people have had Bell's palsy and it's resolved over time by appearances, but when you check the orbicularis strength, you might find that it's decreased significantly compared to the unaffected side. And that's something good to know before you do a blepharoplasty surgery to make sure you're not going to induce any lag ophthalmos postoperatively. Okay? And then I want you to do me a favor, clench your teeth like that. Does your jaw feel aligned? Mm-hmm. Okay. Any pain when you bite down on your jaw? Mm-mm. No? Okay. All right, and so when I'm doing a facial fracture exam, I'm also going to check for instability or movement in the maxilla. So excuse me 1 second while I put on a glove. Okay, and I'm going to put my gloved hand in your mouth, and I'm going to go on either side of your upper teeth, and I want to see if there's any mobility in your mid-face region, okay? Okay, so I'm going to gently put my gloved hand inside of the patient's mouth. I'm going to go on either side of the upper teeth, and I'm just basically gently wiggling the maxilla back and forth. If there's a lot of instability, you'll feel it, and that will help guide your surgical decision making and also be a reminder for you to make sure that the patient follows a soft diet so that they don't induce further instability until we have a chance for the fractures to heal. Okay, so far everything's looking good. The one other test that we want to really do with an orbital patient, especially if there's concern for an orbital tumor and you want to see if it's vascular or not, there are two things we want to do. One, we want to listen for a bruit, so we're going to auscultate with a stethoscope. Two, we want to check for increased proptosis with Valsalva type maneuvers, as that will push the eye forward with the Valsalva, which will help sort of lead you down one differential diagnosis path. So with the stethoscope, you're actually going to put the stethoscope over a closed eyelid and then listen. And if you hear a bruit, it's a very concerning finding and you want to get imaging as soon as possible, okay? Okay, gently close your eyes for me. Perfect. Good. Very good. Okay, no bruits. All right, and now we want to check the exophthalmometer post-Valsalva. So you want to set your base back to where it was. Hers was at 101. Okay, Meg, here's what I want you to do. I want you to pinch your nose, and then I'm going to have you lean forward and pretend like you're blowing up a balloon or trying to make your ears pop. Basically what I want to do, I want to see your face get red. Okay, so that will mean that we're building up a lot of vascular pressure in your face, okay? So lean over and then blow out and really bear down, use your stomach and everything, so you see her face is turning red. That's perfect. If they'll tolerate, I'll have them do it for up to 20 seconds. I have my exophthalmometer ready to go and have them look straight ahead. I'm going to put it right back and I'm going to look at the eye that I'm worried about first. Okay, and look straight ahead. I want the center of that cornea right on the line, making sure I'm parallel to the floor. Good. Okay, and there's no increase in proptosis or or change in the measurement, so you're doing great.
So if you hold that and cover up your left eye, so you're looking just out of your right eye, and read the lowest line that you could read.
And the top line is VLNE.
Anything on the next line?
DAOF.
And the next line down?
EGNDH.
And the next one?
FZBDE.
Excellent. All right. How about the top line now?
OFLCT.
Okay. Anything on the next line?
APEOTF.
Great. Can you make anything out on the last line there, or the next line down now?
TZVECL.
Excellent. Well, that's 20/20.
Yeah.
That's better than it seemed at start. All right. Then you switch around to the other eye, and can you read that same line?
OFLCT.
And the next?
APEOTF.
And the next one down?
TZVECL.
Okay. And then you can actually switch it to reading numbers, which some people with aphasia can read numbers but not letters. And if people are having a lot of trouble with reading, you can also just move to a single letter. And a lot of people who are having trouble concentrating, or even who just have amblyopia, people who have small areas of field of vision, or scotomata, can see single letters and single numbers better. So can you read that?
9.
And we can just kind of move it down.
6.
And the next one down.
9.
And the next one down.
5.
Fantastic. 2015. Great.
Yeah.
Well done. So when we're checking people's central vision, one of the other things we want to do is check an Amsler grid. And so this is an Amsler grid, and we look at it in each eye individually. So why don't you hold that up again and look at the dot in the middle. And while you're looking at that dot in the center, see if you can see the whole grid. Is there anything missing or wavy or distorted?
No.
No? And normally we would do this, of course, with the near correction. Why don't you switch around to the other eye? Same thing here. While you're looking at the dot, anything missing, wavy, distorted?
No.
It's all good? Absolutely wonderful. All right, so the next thing we move to is color vision testing. Some people use the Ishihara color plate. Some people use the HRR color plates. There's a variety of other ones. I happen to prefer the Ishiharas. You stick with what you're trained with. So why don't you hold that up again so you're looking with your right eye. The first plate is a control plate. It does not actually require color vision. And as you can see, it's really, really large. So people with even extremely impaired vision, 2100, 2400 even, can see this gigantic number. So if you just read through them.
12.
Okay.
8. 29. 5. 3. 1574. 645. 5. 7. 1673.
Okay, and those are the plates that we use routinely for checking for optic nerve dysfunction. Of course, we would normally check the other eye. It is important, if a technician is doing it, that they note that the patient can see the control, even if they can't see any of the other plates, or if they can't see the control. If somebody's got really good vision, they can't see the control plate, that might tell us something about how they're seeing. The other thing is they might be able to see all of the plates in both eyes, but they might really struggle in one eye and do pretty well in the other eye. And that is something that needs to be documented as well. This set of plates can be used for checking what kind of color vision deficit somebody has, if it's protan, deutan. So once you've checked the color vision, we routinely check stereopsis again. And so for that, you need these special glasses that are polarized lenses. They can be used for other interesting purposes as well. So this one here, you ask the patient whether or not they can see. The fly is looking three-dimensional, and I ask you to, can you pinch the wing of the fly? That's a classic answer. Then there's a little more detailed testing. That's gross stereopsis. This is a more detailed. I usually do the animals first. In each row, there's one animal that's sticking up off the page. Can you point to or tell me which one? Excellent. Fast and accurate. Very good. Okay, now in each set of 4 circles, there's one that's sticking up off the page. I want you to tell me or point to each one, and you can hold it yourself.
There, 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 there. Bottom. Can't tell on the last one.
The last one's really hard. Give it a whirl.
Okay.
Excellent. Very well done. I think that one of the things that I like to see is that somebody who's really trying is they're doing this movement of the plates, because that's what somebody who has depth perception does when they're trying to see 3 dimensions. May I have the glasses back? Alrighty, now I'm going to check your pupils. It's kind of a bright light, and I'm going to be shining it in your 2 eyes. I want you to just look right straight ahead. Okay? So the first thing I do when I'm checking somebody's pupils is look at their pupils in room light, and I'm illuminating from below just so that I can see the pupils really nicely. Now we're going to turn the lights off, and I want you to keep looking right straight ahead, and we can look at both of the pupils, again illuminating from below so that we can see the pupils but not actually putting light in them. So then I shine the light in both eyes at the same time and then take away the light from both eyes at the same time. And what I'm looking here for is a nice brisk reaction to the light and a nice brisk reaction to the dark. Both pupils actively dilate in the dark. Light and dark. Now I'm going to do the swinging flashlight sign, where I'm going to shine the light in one eye and then the other, one eye and the other, and I'm looking for the pupil to dilate when I'm going from one eye to the other. The other thing I'm going to check is at near. I want you to look right at my light here and see how nicely her pupils constrict, and look in the distance again and up close. Excellent. And in the distance again. Very nice. The next thing I'm going to do is confrontation visual fields. There are many, many ways of checking the visual fields. Confrontation fields are nice because you have all the equipment right here. First thing I want you to do is cover one of your eyes. That's right, you just use your hand. And then I want you to look right at my nose. And while you're looking at my nose, tell me how many fingers I'm holding.
2, 1, 1, 2,
Total.
3, 4.
Good job. And then we do the other eye. Switch around. Okay. How many fingers am I holding up?
2, 1, 1, 2, 3, 3.
Very good. I thought I was going to fool you, huh? Alrighty. The other thing you can do is you can check for red desaturation. So you can check for red desaturation between the 2 eyes, holding up a nice bright red object. A lot of people use the top of the dilating drops. I want you to look right at this red, and I want you to tell me if it looks the same in both eyes. Looking right at it. Look the same with this eye, and the same with this eye. Look right at it.
Yes.
Look the same?
Yes.
Look the same?
Yes.
Same?
Yes.
And if the patient says it looks different between the 2 eyes, try and get them to describe it, and if they can, quantify the difference. And they may say that the red is half as bright, 50% as bright, and that's something you can actually use for documenting optic nerve dysfunction over time. The other thing you can use these little red balls for is checking visual fields. It's a little more subtle, can be very handy for picking up pituitary tumors. So again, cover one eye and look right here at my nose, and tell me if while you're looking at my nose, both of these little red balls look like they're nice and bright red. Look the same as each other? They look the same as each other? Look the same as each other? Excellent. Switch around to the other eye. Same thing. Look the same as each other? Same? And same?
Yes.
Excellent. Nicely done. Now we're going to check some of the other cranial nerves. We've already checked 2 through visual acuity and color vision. We've checked 3, 4, and 6 by checking eye movements. The next thing we're going to do is check 7 by checking facial movement. So what you want to do is ask the patient to give a nice big smile, show me all your teeth, now relax, raise up your eyebrows, and relax, and squeeze your eyes really, really tight shut. And for this, you can actually see if you can open the patient's eyes. If you've ever tried to put drops in a kid's eyes, you know that you can't open somebody's eyes if they don't want you to. You can see this with request movement, but also just observe as a patient is sitting in front of you. You want to look at the blink speed for very subtle facial weakness. Somebody with a subtle facial nerve palsy can have a slower blink on one side or the other, even if they don't have inability to close the eyes. The other thing you're going to check is the trigeminal nerve. Trigeminal nerve does facial sensation and also the muscles of mastication. So when you're going to check facial sensation, you're going to use a little teeny cotton swab to check corneal sensation. That checks the reflex arc not only of the cornea but also of the facial nerve itself with the blink. So what you do is you warn the patient what's going to be happening, have them look right straight ahead, and come from the side, and with a tiny little wisp of cotton, just very gently touch the cornea, and that will induce a blink. And you can do the same thing on the other side, tiny little blink. Very good. And you can see that you had a nice blink response on both sides. Then now I've got this little cotton swab ready to go, and I can tickle on the forehead, tickle on the cheek, and tickle on the jaw. Those are the 3 different divisions of the trigeminal nerve. The next thing you can do is you can break your little cotton swab and create a little scratchy device, and you can check more of a pinprick type of sensation with a scratch. And you ask the patient, do you feel that all over? Does it feel the same all over? The other thing you can do with the trigeminal nerve is the muscles of mastication. And so I want you to bite down, and you can feel the masseters equally on both sides, and I want you to open your mouth, and you can keep your mouth open. I don't ever try to do mouth closure because that would be foolhardy. There's not that much role for the tuning fork for facial sensation, but it is nice and cold. So we use it to check the sensation of cold in all 3 divisions of the trigeminal nerve. Is it the same all over?
Yes.
Very good. And if you're suspecting that there could be some sort of factitious sensation loss, you can actually check vibration sensation on each side of the forehead. And if the patient says that they can feel the vibration on one side but not the other, that may raise some suspicion. You can also check for hyperactivity of some of the reflexes of the face. You can check the jaw jerk. I want you to open your mouth just a little teeny bit and a little bit less. I'm going to just tap on your jaw, and you can look at the jaw jerk. So you've checked 5 and 7. You can check hearing by rubbing your fingers on either side and asking the patient if they can hear it and if it's the same. You can also do vestibular testing, and there's a variety of ways of checking this. Already you've done your eye movement exam and you've looked for nystagmus, which often indicates a vestibular problem. But one of the things that's very helpful is the head thrust. So when you're looking at the head thrust, what you want to do is ask the patient to look right at your nose, and then you gently grab the patient's head and move it a little bit from side to side like this. And you ask the patient to keep looking right at your nose. And then with warning, you just say, I'm going to move your head abruptly, okay? But you keep looking right at my nose, just like that. And one more time, just like that. And the patient's eyes should be able to remain exactly on your nose with the vestibular ocular reflex. Hers was perfect, of course. And the other thing you can do when you're looking for vestibular problems is look at vestibular ocular reflex suppression. And so for that, it's a little bit more of an active job. What I want you to do is hold your thumb out in front of you like that, and I want you to look right at your thumb. Keep your head pointed straight ahead, and then I can move your chair around while you keep looking right at your thumb. So I want you to look right at your thumb, and here we go. Keep looking right at it, and you can give it a nice little vigorous push, and she's able to maintain fixation on her thumb at all times. So you can relax. So the next part of the testing would be your gag reflex, which tests 9 and 10. And so I want you to open your mouth real wide and say ah.
Ah.
So the first thing you can do is you can see that her palate is elevating symmetrically. And then if you have a tongue depressor, you can actually create a gag. I'm not sure that that's absolutely necessary if somebody doesn't have specific sensation loss in their throat, or if they haven't been having trouble swallowing, or if they're not actually having elevation of their palate appropriately. Then you can move down to 11, which is the spinal accessory nerve, and I want you to push your face against my hand, turn your head. There you go, just like that, and over here, and then shrug your shoulders up, and then H, hypoglossal, stick your tongue all the way out. And you can ask the person to put your tongue back in. Now put your tongue in your cheek here, and good, and over here, excellent. And even just looking at the tongue, often if there's trouble with hypoglossal nerve, you can see atrophy of the tongue. The next thing we're going to do is the fundus examination, which you can do with a handheld direct ophthalmoscope, which is falling somewhat out of favor, but is hugely helpful for almost all incidents. So what you want to do is get everything set up so that you can do this as comfortably as possible. So what you're going to ask the patient to do is look right straight ahead off in the distance. If they're focused up close, their pupil will get smaller, and that's not what you need. You choose a smallish, for an undilated pupil, you want to choose a smallish light, not too bright. And then it's all about feedback, sensory feedback. So you're going to be having very poor vision for what's going on around you when this is happening, so you need to be able to know where the patient is relative to you, because in essence you're looking through a little keyhole. And if you've ever looked through a keyhole, which I know nobody ever does, but if you did look through a keyhole, you know that you have to get right up close. The closer you are to the keyhole, the better you can see through it. And she's got pretty small pupils, so we're going to need to really get ourselves coordinated to be able to see here. So, once you look right straight ahead, then you get yourself set so you can see the red reflex. And you can see my little pinkies out here because I want to be able to stop myself before I actually bash foreheads with her. So here we go, we're going to come forward. I am looking at the red reflex, coming forward, coming forward. I just touch her cheek with my finger here, and I'm right on the optic nerve. And I can see beautiful venous pulsations and a nice healthy looking optic nerve, and I can pop over here and just take a quick look at her fovea. Then you want to do it on the other side. And again, I'm using my hand on her shoulder, or I can use it on her head to make sure that I have good sense of where she is once my eyes are covered up. Again, looking right straight ahead, I'm going to come in and right in there on her optic nerve. And she's the world's most cooperative patient, so it works really well. We've covered the remainder of the cranial nerves, 2 through 12. You could check 1 if you wanted to, if you're concerned about a orbital frontal meningioma, for instance, and somebody who's got Foster-Kennedy syndrome. You can check somebody's sensation of smell with coffee. Try not to use alcohol swabs because they are doing more checking nasal pain rather than smell. So we have checked the remainder of the cranial nerves, 2 through 12, and we've done the fundus examination. I hope.
We're going to start today with the Hardy-Rand-Rittler pseudo-isochromatic color plates. This is one way that you can test color vision. The nice thing about these plates is that it can screen for red-green defects and for blue-yellow defects. The Ishihara color plates primarily just screen for red-green defects. So generally you want to examine patients who have an acuity of around 2200 or so. The test starts out with 4 different control plates. So you want to have the patient test one eye at a time. So can you go ahead and, yeah, that's perfect. We'll test your left eye first. So you ask the patient to describe what they see on the test plate.
0x.
Good. So you go through all 4 of these. The 4th is a blank plate. And then the next 6 plates are the screening test. And so again, you have the patient test one eye at a time, ask them to go through each of the plates.
0x. Just 0. X triangle. O triangle. O. X.
Very good. And then you can do the same thing with the other eye. Okay, so now we're going to be testing for an afferent pupillary defect, and we'll talk about how to measure the size of the defect. All you need is a muscle light and some neutral density filters. The one that we have here are in 0.3 log unit increments, and we have a 0.3, 0.6, and 0.9. So you're going to start out by asking the patient to focus on something in the distance. You're going to use the muscle light to shine into each eye. And then you do the swinging light test where you go back and forth between the 2 pupils. An afferent pupillary defect is present if the pupil dilates when the light reaches it again in the swinging light test. So for demonstration purposes, I'm going to try to induce an afferent pupillary defect on the left side. So for this instance, I'm going to hold the neutral density filter over the left eye. The left eye will perceive less light, and the pupil should dilate on the swinging light test. So if you'll just look straight ahead again for me. This is the swinging light test. Instead of constricting on the left side, the pupil dilates slightly. I'm going to demonstrate the ocular motility exam. When we do the exam, we differentiate between ductions and versions. Ductions are the movements of one eye by itself. Versions are the movement of the eyes together. Usually we just begin with versions, and if there is an abnormality, then you can add inductions. But I think the easiest way to do it is to have the patient follow one finger. You can do this with both eyes open for versions, and you just ask the patient to follow your finger as you make an H in the air, and you'll bring the eyes through all 6 cardinal directions of gaze. And as you do that, you want to watch the eyes, watch for smooth pursuit of your finger. It shouldn't be, the eye should not be jumping back and forth. Once you've done that and you've found that the eye moves normally, you can test saccades. So in order to do that, you have the patient focus at a target off to the side. I like to use my thumb. And then now focus on my nose. Back to my thumb, back to my nose. So that's testing a horizontal saccade as you watch the eye jump between. And then you can test vertical saccades. Look at my thumb, back to my nose, thumb, nose. All right. For the next part of the exam, we'll talk about the alignment of the eyes. So what we do is have the patient focus at a distant target. So can you look at that letter down there? Mm-hmm. You can see that without your glasses?
Yes.
Okay. And we usually start out with the cover-uncover test. So this looks for tropia or a manifest deviation, a deviation that's present even with binocular viewing. So go ahead and look right at the 6 for me. So you're going to cover one eye and then uncover it. And you watch for movement or refixation movements of each eye. So you cover, uncover. Then you do the other side. Cover, uncover. So her eyes are very well aligned. For the next part of the test, we do the cross-cover test, which looks for aphoria. That's a latent deviation, or one that's only present when you break binocular fusion. So look again at the 6 for me. So you cover the right eye, and then directly switch to the left eye, and then back to the right. So you're breaking the binocular fusion. And again, you watch for any refixation movements of each eye. This is a prism bar. This is one of the tools that we use in neuro-ophthalmology to measure deviations. Kind of makes it fast and quick. This is a horizontal prism bar. You can tell because the base is oriented out to the side. In a vertical prism bar, the base will be oriented in the bottom portion of each prism. And so if you're looking to measure a deviation, you point the apex in the direction of the deviation, you hold it over one eye, and if you want to measure aphoria, you do the cross-cover test, adding increasing amounts of prism until you've neutralized the deviation. For her, I'm actually inducing one because she's very well aligned. For the next test, we're going to do the Maddox rod. Thank you. I have an assistant here. The Maddox rod is a series of cylinders, and you can have the patient orient them vertically, which will give you a horizontal red line, or you can have them oriented horizontally, which gives a vertical red line. The idea is that you give the eyes 2 very dissimilar images, and so you can very precisely measure the deviation. So let me have you hold that up over the right eye, and you have your assistant hold a muscle light down at the end of the room. So can you appreciate that there's a horizontal red line when you're looking through your right eye?
Yes.
Yep, and you can kind of rotate that to make it perfectly parallel with the floor. Okay, so when you're looking down at that red light, or the white light, sorry, is the white light above or below the red line? Or right on?
Right on it.
So she's very well aligned. So the light and the line are at the same level. So now we're going to turn. There you go. Turn your head. Good. So this is measuring her in left gaze. So go ahead and look back at the light. Mm-hmm. Is the light above or below the red line?
It's right on it.
Right on it. So perfectly aligned there. And how about there in right gaze?
Right on it.
Very good. You can also do it in down gaze.
Exactly on it.
And up gaze.
Right
Okay, I'm going to show you how to measure the deviation with a Maddox rat. So let me again have you hold that up there. So she's very well aligned, but for argument's sake, let's pretend that she had a vertical deviation. So let's pretend that the white light is above the red line. Okay. So you can use a vertical prism bar and add more prism. Since the white light is above, I'm going to be correcting a left hypo deviation. But you add increasing prism until the patient tells you that the white light and the red line are perfectly aligned. Okay. I'm going to show you now how the neuro-ophthalmologists use the Hertel X ophthalmometer to measure the position of the globe within the orbit. So this is the Hertel. These are the index points. These are the mirrors. And this is the ruler that you use to measure the base. So what you want to do is take the index points, and we like to put them just inside the temporal orbital rim, just slightly inferiorly to the lateral canthus. So while the patient is positioned that way, you close one eye, look in the mirror, and you'll see two red lines. The point of the red lines are to eliminate parallax. So you line those two up when you're taking the measurement. You look in the mirror, and you can see the corneal apex. And so you just use one eye open, ask the patient to look at your open eye, and you mark in your head where the corneal apex falls. You do the same thing on the other side. And you always want to make sure that you take the base measurement. This is the distance between the two index points. So today we've reviewed some of the techniques for color vision testing, APD testing, the ocular motility exam, and the alignment exam.
And so we'll start into the slit lamp exam. So first thing you're going to do is you want to make sure your patient is somewhat relaxed. Patients will be very anxious. You want to let them know that you care about them. And so I always kind of tell patients that we're going to be doing a slit lamp exam, and I try to make sure they're comfortable. My patient population is generally a little bit more elderly, and so you want to make sure that their back, their neck, and things aren't contorted. If they're comfortable in the slit lamp, you're going to be comfortable and be able to spend more time trying to find the diseases. So first thing you'll do is bring the slit lamp over towards the patient. You'll kind of look where they are. The chin rest, I always eyeball where their chin is, and I'll bring it down to their level. However, you'll see a black mark here on the slit lamp. That needs to be level with the lateral canthus, or the lateral part of where the two eyelids come together. And so you're going to be lining that up so that it'll be their right eye is lined up with this black mark. And so that's one of the first key parts of getting a patient into the slit lamp. So you ask them to please come forward here, chin down in here, forehead up against the headrest. It's important they try to keep their head up against the headrest. You don't have to hound it too much. It's not the end of the world. And then I'm looking, you can't see it right now, but I'm currently looking at that black mark on the right side, and I'm looking at the patient's lateral canthus, and I'm going to make sure it's lined up. And it's nicely lined up right there. So next thing I'll do is there are different settings on the power of the beam itself. I usually set it on the half. There's a half and a 1. You don't need to blast them with light, but at the same time, you brought them here to do an eye exam, so you might as well make sure you have enough light to be able to see. Sometimes patients will be light sensitive. Their pupils are dilated, they may have inflammation or redness, or for whatever reason they may be light sensitive. But I do think it's important to make sure you use enough light so you can see, and then just be patient with the patient to make sure that you don't blast them with light too bad. So as a general rule, you're going to start with the right eye first and then do the left eye. And you look at the eyelids, and then you'll look at the conjunctiva, and then the cornea, and then the anterior chamber, and then the iris, and then the lens, and then you go back to the fun part of the exam, the retina exam. So make sure you concentrate on those first initial things. But as a retina specialist, I look at those areas to make sure they look okay, and then I'm really thinking about getting back to where the fun starts, which is behind the iris. All right, so first things first, you'll notice on the slit lamp, there's a joystick down below that can bring things into focus by moving it forward and back. And also you can move it left to right, and then you can spin it, and spinning it raises it up and down so you can get the eye and level. Also on the slit lamp, these are the main two knobs you're going to use. This upper knob that controls the lateral movement of the beam, the side-to-side movement of the beam. It also increases the width. And so by spinning the knob, and you can actually go all the way in and all the way out and spin it all the way around, you widen the beam. And so at different parts of the exam, you're going to widen or narrow the beam depending on what you're looking at. Also at the top here, it gives a size of the beam. So this increases the width, this increases the height. The knob that's up here at the top increases the height of the beam. On the slit lamp itself, it actually gives a millimeter measurement. So let's say that you're measuring the size of a corneal abrasion, or more importantly for me as a retina specialist, if you're looking at the size of a hyphema, which is blood buildup in the anterior chamber, you can actually measure the size of that hyphema or how tall it is, and then record that down so that later on you can record that, oh, it was 5 millimeter hyphema this week, and then a week later it went down to 3 millimeters. So obviously having less hyphema is better than more hyphema, so you can track that. That's especially important with looking at corneal ulcers or corneal abrasions or things like that. But in the retina world, we use it especially to measure the size of hyphemas or blood in the anterior chamber. So I'm just going to start her exam on her right eye. I start out by looking at her eyelids, and then I look at the conjunctiva and then the cornea. When you come to your cornea exam, that'll be a time where you start to narrow the beam. After the cornea, you're going to look at the anterior chamber, and in the retina world, we do a lot of uveitis or inflammation inside of the eye exams. And so to look in the anterior chamber, you're going to narrow the beam, you're going to make it thin and narrow and focus in on the iris. And once you have the iris border or the pupillary border nice and focused, you can pull back a little bit. Also, you want to turn the beam up, and that will allow you, by focusing on the iris border, having a focus and then pulling back just a little bit or focusing out, that will allow you to see if there's any inflammation in the anterior chamber, and this patient doesn't have any inflammation in her anterior chamber. So after looking at the cornea, then the anterior chamber, the iris itself, then you'll look at the lens and look for signs of cataractus changes in the lens. And then after the lens, you'll look back into where, like I say, where the fun starts in the posterior segment exam of the eye. One of the things with patients that I will always look at, and I think is critical in doing a retina exam, is to look at their vitreous. And you can see the vitreous and the fibers or the collagen fibers of the vitreous right in the space behind the iris. It's a good place to see that. It'll allow you to look for blood there, inflammation, and also for age-related or synuretic changes of the vitreous. And I'll look at that every single exam, no matter what I'm doing, and that can give me signs of or an idea if there may be some sort of pathology backed by the retina. One of the common exams that we do in the retina world is when a patient has a new onset of flashing light and floaters. And if they were to have a tear in their retina, the retinal tear would release pigment cells or RPE cells into the vitreous, and that would look like a tobacco dust or little teeny cells floating in the vitreous behind the lens, or a Schaefer sign it's called. And so how you look for a Schaefer sign is you focus in on the lens, narrow the beam, and make sure it's nice and bright, and then you tell the patient to look up, look down, and look straight ahead. And then as they're doing that, you move the joystick backward and forward until you can see the little collagen fibers. And intertwined or floating around those collagen fibers could be those pigment cells or the tobacco dust cells from a retinal tear, or inflammation or blood or something like that. And so after seeing that, then you're going to go to the posterior segment exam of the eye. Commonly, there are two main types of lenses that you'll use. The purpose of lenses in doing a retina exam is to be able to magnify the images in the back of the eye. The common ones that are used are a 78 diopter lens and a 90 diopter lens. I'm using a 78 diopter lens. And there's some little tricks to be able to pick up the posterior segment of the eye or the retina using this lens. First and foremost, I like to do my posterior segment exam using the 78 diopter lens, and I like to do it with my beam not shifted to one side or slanted to one side or the other, but straight on. I feel like that helps me to focus it. Also, what I do is I make my beam a little bit taller and I make it a little bit narrower. And then once I have the nerve and the blood vessels and the macula in focus, Then I'll change the size a little bit. I'll shorten the beam down and I'll widen it just a little bit, and that gives me a lit up area that's a little bit easier to see, and then that'll help me to focus in on the nerve and the blood vessels and that sort of thing. So again, when doing the fundus exam from the slit lamp, it's good to start out with a little bit narrower beam, a little bit taller beam until you get the nerve and the macula and the blood vessels in focus, and then shorten it and widen a little bit to start examining around. As a general rule, you're going to hold the lens with 2 fingers, your pointer finger and your thumb, and then you're going to use your pinky and a lot of times your ring finger either resting on the patient's forehead or on the forehead rest itself, the plastic forehead rest. And then the trick of how to do this is you're going to put it up in front of their eye without touching it, but just in front of where their eyebrow is. And then you'll look in through the slit lamp, and once you find their pupil, you're going to pull back a little bit till you see the orange beam come in focus, okay? When the patient is dilated, it's much easier to do. On a non-dilated patient, it takes a little bit more side to side and up and down movement to be able to get the nerve and the retina and the macula into view and into focus. So first things first, now that I've got the nerve and the macula in focus, I'm going to narrow the beam, shorten it, widen it just a hair. First thing you do when you look in the back of the eye is to look at the nerve of the eye. You'll look at the size, you'll look at the optic cup, and you'll look at the borders of the nerve, and you'll look at the blood vessels coming out of the nerve. In the retina world, we commonly see patients that have diabetes and that have macular degeneration or vein occlusions. There's inflammations, there's all sorts of other things, but each of these disorders are commonly associated with something going on with blood vessels. And the blood vessels in the retina most of them come from or start or originate from the optic nerve or travel through the optic nerve. And so you're going to make sure as you look at the nerve of the eye to look at what the blood vessels are doing there too. So we focused in on the nerve of the eye, and after seeing the nerve and looking at the blood vessels, you are going to pull towards the patient's nose, all right? And that will shift the beam over towards the macula. The macula and the fovea are the high-priced real estate. That's where the majority of vision occurs and where the majority of retinal diseases have their source. And macular degeneration, diabetes, when patients have issues with these disorders and many other disorders, when there's swelling or bleeding in the macula, it will be the thing that affects their vision and why they came in to see you with vision complaints. And so again, the key is, and I guess a good point to bring up with that is that these lenses reverse the images up and down and side to side. So the macula is always located temporal or lateral to the nerve of the eye anatomically. However, when you're doing your exam, to see it, you're going to pull nasal or towards the nose to be able to get those into view. So after you see the nerve, you're going to pull nasal and swing the slit lamp over towards the macula to get a good view. After looking at the macula, then generally I will swing and look at the blood vessels. I'll travel along the superior temporal arcade and the inferior temporal arcade and get a good look at the blood vessels. And then I'll look a little bit past that. In general, with the 78 diopter lens and the 90 diopter lens, you can see into the mid-periphery, past the macula a little bit. From there, you're going to take over with your indirect ophthalmic exam. And so those are the basics of the slit lamp exam, looking at the posterior segment of the eye. And now we'll switch over and go to the indirect ophthalmoscopy. All right, so we have completed our slit lamp exam and our posterior segment exam using the 70 and the 90 diopter lens. And now that we've looked at the posterior segment, the nerve, the blood vessels, the macula, the mid-periphery, we're going to try to look out farther into the retina, so more out in the periphery of the retinal exam. And in order to be able to do this, we commonly use some different tools. One is called the indirect ophthalmoscope. This is the indirect ophthalmoscope, and then we use two main lenses, a 20 diopter lens and a 28 diopter lens. And these lenses are such that allows for a less magnified but more wide field view of the back of the eye, thus being able to see out into the far periphery of the retina. And so first of all, again, key concept in learning this is to take the time to learn it and to get comfortable by making sure that the beams, the head positioning, the width of your two eyepieces are in the right location so that you're comfortable. You're going to better be able to assess and view the patient's posterior segment and out into the periphery of their eye. So I am going to go ahead and spin. So the cord's on my other side. And then in doing this, you're going to put it on. The upper knob will shorten the height of this sitting on your head, and you want to make sure the eyepieces are level with your eye. The back knob will tighten it. In general, you never have to really touch this one. It's usually set right, and you just tighten and untighten it to get it onto your head. So I just turned it counterclockwise, which loosens it, and then I'll turn it back clockwise to tighten it. The two eyepieces are set correctly. They're about level with my eye, if you can see that. And then there's a knob here on the left that turns the beam on and off. Okay? You want to turn the beam on, bring the piece here so it's just touching your nose. That generally ends up being about the right location. Not that it's smushing it, but it's just touching your nose. That way the kind of horizontal position is located correctly in relationship to your eyes. All right, and then as you look through, you're going to see a beam of light. And I'm going to turn that up to its highest because we're kind of lit up here in this room. In a dark room, it'll be a lot easier to see. The beam has different sizes. There's a wide beam, a medium beam, and a small narrow beam. So 3 different sizes. In general, you're not going to use the narrow one very often. If there's a very, very small pupil, you might use the narrow beam, but it gives a very small view into the retina. So I basically never use that little teeny beam. The medium one I use for a lot of my exams except for when I'm doing a scleral depressed exam. When I'm doing a scleral depressed exam, I'll use the wide beam here. Okay? Sometimes in starting out, obviously with more of a beam you get more light into the eye. Sometimes it makes the focusing in and out, the field of view a little bit better. You may want to start out using the wide beam and then shift over to the medium beam as you do your exam. But again, I generally use the medium-sized beam for most of my periphery exam, except when I'm doing a scleral depressed exam, and then I use the wide beam. But you'll just have to play with it and decide what each of you like to do best. So, first things first, as I look at my beam, and I'm looking through my oculars, the beam is a little bit down towards the bottom of my view. I want it right in the center. If you put it up here, you're not going to be able to tell. You got to put the beam a little bit away. Sometimes I'll shine it on the patient and do it, or sometimes I'll hold out my hand, okay? And so I've got it there. There's a knob here on the left. That moves the beam up and down, okay? So just move it so it's right in the center of your oculars. Also, I open and close each of my eyes to make sure that the beam itself is located in the center for each eye. And it's actually going to be the center a little bit left for the right eye and the center a little bit right for the left eye. But this is a critical concept depending on the distance between your own two pupils. You want to make sure in each eye that you can see the entire beam. Okay? And that way, when the two eyes work together, it'll give you the widest field of view, or it may cut off part of your view on one particular side, and that'll make it harder to focus in on that area. So, again, make sure the beam, literally every exam, I open and close each of my eyes, and I make sure that that beam is nice and centered for each eye. It'll be shifted a little bit nasal for each, and then as you open up both eyes, it should be right in the middle. I think that's a critical step. I literally do it. Thousands of time doing that. I make sure that that's centered right because I know that'll help me to get my best possible view of the periphery of the patient's retina. Okay? So, that's basically the nuts and bolts of getting the indirect ophthalmoscope ready. So next I'm going to go to my patient who's been patiently waiting for us. So, again, key concept, do the exam the same way every single time, all right? I start with the right eye, I go to the left eye. What I'm going to do and what I do is first of all, and there's different ways this can be done, but what I do is I start superior and I go lateral every single time, so I go temporal. And I do that with both eyes. So on the right eye, I'm going counterclockwise, and the left eye, I go clockwise. And by doing the same exam every single time, when I note changes, there's a change at 9 o'clock, or there's a change at 2 o'clock, or 4 o'clock, by doing the exact same rotation every single time, hundreds of times over, I then don't have to think twice about where I saw a particular change. So when I write it down on my exam, or I type it into my EMR, or I put it onto my drawing, because I do my exam the same every time, it helps me to remember where I saw the changes. I personally think that's a critical step in doing the ophthalmic posterior segment far peripheral exam. Do the same thing every single time, because let me tell you, when you have to start drawing stuff in and writing stuff down, and if you see multiple changes in the eyes, it can become very complicated, and you don't have to get up and do the exam over and over again. So the patient will stay nice and relaxed. It'll be like they're at the barber shop or the beauty salon, because you're going to position their head around a little bit. And so I'll start with the right eye. I'll tilt their chin just a little bit to the left. All right. Key concept in holding this, it's like the 78 or the 90 diopter lens. You're going to use your thumb and your pointer finger to hold the lens. You use your pinky and your ring finger, okay, to rest on the patient's chin or their cheekbone. And then the key in getting the retina in view is you're going to put the lens in front of their eye. You'll be able to actually see in pretty good clarity their cornea and iris, and you'll see an orange-red reflex. When you see that, also notice how my head is positioned, okay? Depending on where your head is, and you'll learn to adjust this back and forth in relationship to the lens, there'll be a distance that will be perfect for you depending on your size, your arm length, curvature of your hand. There'll be a certain distance between those two that is perfect for you, of where every single time you'll get that retina in focus. So I'm used to it. I know kind of where mine is. And so again, you'll focus in, you'll see the cornea, the iris, and clarity. You'll see an orange-red reflex. When you see that, with your thumb and your pointer finger, you're going to pull that lens out towards your eye here. Sometimes you have to move in a little bit, sometimes you don't. In general, it's a good habit to learn to where to keep your head distance the same and just learn to move this lens in and out. Once you have the 20 or the 28 diopter lens in the position where the view fills up the whole inside of the lens, so you'll see the whole retina inside of the lens, not part of it or not over here, but filling up the whole lens, that's the right location. And then you learn to look at all parts of the retina with the view itself being filled with the retinal exam. So, first thing I do, again, pinky on the cheek. I already know where my head position is. I look at the cornea, the iris. I see my orange reflex of the posterior segment. I pull backwards until the retina is in view. Then I tell the patient to look up. Same thing. I'm moving the lens forward and back. My head generally stays still because I know where that proper position is. I see the orange reflex. I pull backwards. One of the little subtleties of this, you'll learn to be fluid with your fingers, because as you pull back, because it's a round surface, you're going to have to turn it too a little bit. That's okay. So you'll pull and turn, and you'll pick up the subtlety of that. So forward, I see the orange reflex. I pull back with my fingers. It's turning clockwise just a little bit. I look up at her superior retina, and then you look up and to the right. So this is her right eye. I always start superior and then work temporal. So up and to the right, and then look over to the right. All right. To see down and to the right really well, you can come from up here or even from the other side of the patient. All right. Look down and to the right. So in, I see the orange reflex. I pull back. There's a nice view of her retina. Look straight down. Down and to the left. Sometimes, let me tell you another key thing. Sometimes there may be a language barrier. We have a lot of patients that speak other languages here in the Salt Lake Valley. We also have a very large Hispanic population, so learning Spanish is a very nice thing. And sometimes if there's a little bit of a language barrier, if you just gently tap, well, you don't even have to say you're tapping, you just tap. Especially patients that can't hear also, you just tap in the location you want them to lightly, they will naturally look there. It works very well. And if you have a patient you feel like you're just not communicating with, or they don't want to hear you, just tap before you focus, and they'll just naturally look in that location. So look down and to the left, and then over to the left, and I'll just kind of tap where I want them to lightly. You don't want to pound them, obviously. Look up and to the left, And then I have them at the very end look right at me. And at that right at me exam, I get a good view of the nerve, the blood vessels, the macula again. And then that's the exam for the right eye. As I'm going, I will make a note of where I saw change. Well, I saw a little retinal defect or a retinal tear up at 10 o'clock. In my head, I think retinal tear off at 10 o'clock. As I'm going, I've learned I'll kind of repeat that in my head. Okay, saw a tear at 10, and I'm keep going to my exam. Remember, you have a tear at 10, and that way when I get down, I'm going to record my findings. I'll write them down. But there's a lot of things to think about. So now I do the left eye. So same thing, I'll make sure their head is in the right position. I'll have them look straight up, and then I work temporal up and to the left, over to the left, down and to the left, straight down at your toes. Very good. Then for this, you could rotate to the other side of the body. It's easier. Or you could turn their head this way, then look down and to the right, over to the right, up and to the right. Very good. And so that's the posterior segment exam. The other thing that we'll commonly do is to do scleral depression, and that's where you use a little scleral depressor, you give them a numbing drop, and then you do that same peripheral exam with the scleral depressor around the side of the eye that allows you to see out to the ora serrata. So the posterior segment of the eye is like a fishbowl, where you have an opening in the top, and just like when you look down in the fishbowl, you can see everything that's straight back. Well, you can't see what's up underneath the rim of the fishbowl unless you stuck your head in there and looked up there. And so the scleral depressor allows you to press in underneath that lid of the fishbowl so you can see way out to the side of the eye. And that's commonly where disease processes occurs, out by the ora serrata.